Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this episode of the NEI podcast, we are talking about erasing the stigma of serious mental illness, and we are discussing the Brief Psychiatric Rating Scale. It is my honor and privilege to interview Dr. Donna Rolin and Dr. Joseph Ventura. Dr. Rolin is a clinical associate professor at the University of Texas, Austin. She is also the director of Psychiatric Mental Health Nurse Practitioner Graduate Program at the University of Texas, Austin. She is the clinical nurse expert on the SMI Advisor program, and she is also on the board of directors for APNA. Dr. Joseph Ventura is a research psychologist at the UCLA Department of Psychiatry and Behavioral Sciences. He is also the clinical expert consultant at the SMI Advisor program, and he is also the director of the Diagnosis and Symptom Assessment at the UCLA Aftercare Research Program, which specializes in the treatment of early course schizophrenia. Welcome, Dr. Joseph Ventura.
Thank you.
And welcome, Dr. Donna Rolin.
Thanks for having us.
My first question for either of you is, we know that you're both part of an interdisciplinary team at the APA SMI Advisor program, and I understand that this is a clinical support system program for patients with serious mental illness, and that it's a joint initiative between the American Psychiatric Association and the Substance Abuse and Mental Health Services Administration, or SAMSHA. Could you each tell us a little bit more about this program and how each of you got involved?
Sure. I'll start. The SMI Advisor, as you said, is an initiative that APA oversees. It's now in its third year, and we have gathered clinicians from different disciplines and across the country to create educational content about any issues that are related to serious mental illness, or SMI, for other clinicians and also for individuals who have SMI and their families. Our clinical expert team includes several psychiatrists, psychologists, one psychiatric mental health nurse practitioner, that's me, a peer support specialist, a representative of NAMI, or National Alliance on Mental Illness, and our newest addition is a social worker who's joined the team. The way that I got involved was being approached by the APNA executive director, and he had been approached by APA looking for a good fit for a psychiatric mental health nurse practitioner and nurse, really, to be part of this interdisciplinary team. And I've been a psychiatric nurse. I've had experience since 1997, and I've been in advanced practice since 2002. So doing that math is starting to get scary. And then I've been also in nursing education since 2002 as well. And so I feel like I'm a pretty good fit for this role, and it's been really fun.
Excellent. And Dr. Ventura, do you want to share with us how you got involved?
Sure. Being part of the UCLA Department of Psychiatry, I have many colleagues who are psychiatrists and several who are psychologists. One of my psychiatrist colleagues is named Alex Young, and he's been a longstanding services researcher and has been interested in SMI for a number of years. And he approached me and asked me if I would be interested in being part of this really great group of individuals and this great website called SMI Advisor. And so I literally jumped at the chance to be able to do it. One of the reasons Dr. Young wanted me to be involved is because of my longstanding involvement in first episode or early onset schizophrenia. I've worked in the UCLA Aftercare program for a number of years. It's a joint clinical and research program. And so I've been able to proudly be part of an effort funded by the NIMH to develop programs and interventions for people in the early phase of schizophrenia or related psychotic disorders. The reason all of this is exciting right now is because, as I think Dr. Rolin would agree with me, we know a lot more about how to treat individuals who have SMI and how to help their families. And so the
Right.
SMI Advisor website really embodies a lot of that knowledge and information. It's as an extraordinary resource. And so that's how I got involved. And it's just been wonderful to learn so much from all my colleagues.
I would agree with that. I will also add that my clinical experience has been predominantly in inpatient psychiatry. And then once I moved back down to Texas, more community psychiatry.
Wow, that's great for both of you. Could you tell me a little bit more about what is it that's unique about this program in terms of treating serious mental illness? How is this program different?
Well, I'll speak to that initially. The SMI Advisor website is truly an extraordinary resource because not only is it comprehensive and contains several different resources, but all of the information that's there has been reviewed by our expert team, of which Dr. Rolin and I are part of. So we have our team and the other folks that she mentioned evaluate, for example, webinars or articles or other resources that are published by SAMSHA and other groups. And before that information gets onto the website, we make sure that it's a high quality and that the information would be useful. The website itself is separated into two primary categories. One is it's focused on clinicians, and the other segment of it is focused on individuals and families. So if you're an individual or family, you can go to the portions of the website that have information specifically geared toward individuals and their families. If you're a clinician, I think of it as a kind of a colleague almost, because you can get a lot of information, everything from new medications and what their side effects might be, information about how to prevent and work with individuals who have suicidality, depression, anxiety. You can learn about individuals who are dealing with substance abuse problems. So there's a lot of information, and some of it is presented in written form. A lot of it is presented through webinars. There are a number of webinars that have been created, and they're absolutely fantastic. They're experts in the field who have been recorded and placed onto the website. The website is very searchable, so there are sections that have to do with these webinars or written information. You can ask a question, so there's a search button, a search tab. You can, as a clinician, you can request a consultation. If you're a family member, you can search the knowledge base, request guidance. There's even a little chat bot, if you know what I mean. It's a little box where you type in a question, so you can ask anything like, oh, my son or daughter is having trouble with being able to have enough energy to go to work, or they're having trouble motivating themselves to attend school, and you can get an answer about the resources for that. So those are some of the really great features of the website.
That's great. Now, I know you touched on this a little bit, but what sorts of resources are available for clinicians through this program, and how can they get more involved?
I will elaborate on that. We have so many educational services that Dr. Ventura had described. I'll start with the educational webinars. These run live each week, basically, usually on Thursdays or Fridays currently. And then once the live session is over, they're available on demand for a few years beyond their live run. We offer free continuing education credits for multiple disciplines, whichever are most appropriate for the specific topics. And so sometimes we can keep those archived for 2 years or 3 years, just depending on who the accrediting body was for those credits. One of the most recent webinars that we had, I'll give you an example, was on sexual side effects of psychotropic meds, which is a really common issue that individuals experience, and sometimes a reason for discontinuing meds or having to select something else. So that was really well attended and kind of an exciting topic.
That's great.
Thanks. We have also online kind of interactive modules. I was involved in a few of them. There's one I can think of about integrated psychiatric and physical health care. and another on intellectual disabilities that might be concurrent with a serious mental illness for some individuals. And then we have another section that Joe mentioned on the knowledge base. It's searchable and for either clinicians or individuals and families, depending on which part of the website you're in, you can find some short clinical tips or really kind of digestible material that's evidence informed and has also been embedded by our clinical expert team.
That's great. It sounds like there's lots of resources.
Yeah, there's so much available. We also have an app, the SMI Advisor app, that includes some screening tools and access to all of the other services. And another app is in development that's about to launch from our group that's to assist clinicians and individuals in creating psychiatric advance directives. And lastly, I will mention the consultation service that we have for clinicians. Dr. Ventura did mention it. I'd just like to add that clinicians can submit a question. They could submit something about requesting evidence-based resources or even a topic that's about a type of clinical case or issue that they run into in their practice. And in 24 business hours, someone from our clinical expert team, whoever is the most appropriate to answer that question, will send them back a pretty detailed response. And these are all free and confidential.
Wow, that's amazing. This sounds wonderful in terms of what resources are available for clinicians and then also for families. As Dr. Ventura, I think you were talking about this just a little bit. I'd like to ask what types of resources are available for families and for individuals through this program. If you can go into a little bit more detail on that.
Sure. If you go to the website, you'll find a banner, and there are three possibilities of ways to obtain information. One is called guidance, one we've alluded to already, knowledge base, and then there's one that's in first-person language. So the resources that are available, what's important to know about them is that they're evidence-based. This is a new approach in our field to make sure that the treatments that are recommended have some research behind them. So that's what we mean by evidence-based. So SMI Advisor in the website is very focused on and very aware of the fact that any treatment or program or approach that we recommend is in fact evidence-based. So there's research to support the fact that that approach is helpful. You know, we haven't said this yet, but I want to say so before I forget. There's no cost whatsoever for any of these services that Dr. Rolin and I have been mentioning. Even that consult service for clinicians, if they want to talk to one of us, is also provided at no cost. The whole idea and all of this is all geared towards providing this information to clinicians, but to individuals and families. And what I like about it is that the information provided to individuals and families is at a very high level. It's a very high quality information. It's not watered down because it's a person with SMI or a family member. You know, you don't like think, oh, well, you know, they don't really know that much. All the information is pretty much at the same level as it would be provided to clinicians. But yeah, what's different about it is that in some cases we remove some of the jargon so that it's readable. So it's really user friendly. But for example, it's some of the same resources that were mentioned for clinicians. So there are a number of webinars that are geared, like one of them has to do with navigating the criminal justice system. There's a webinar on peer specialists. Mood disorders. There's one on schizophrenia. Here's one that I think is really helpful for individuals with SMI. It's called the self-management of symptoms of SMI. So here, some individuals prefer to work on their symptoms or work on the challenges that they're facing on their own, and they want to see what they could do without extra help. And so this provides very specific suggestions.
Yeah, that's great.
Yeah. And yeah, a lot of it is geared towards suicide prevention and crisis management. And then, there is that chat bot. So anybody with SMI or a family member could just literally type in the question, because when you click on the chat bot, the first question you're asked is, are you a clinician who treats someone with SMI? And if you say no, then you get a series of algorithms that lead you to information for individuals and families.
Got it. Wow, that's great. And so that leads me to my next question, which is when it comes to serious mental illness, how important do you think patient education is? And what about education for the family or for the caregivers?
Well, as a longtime educator myself, my opinion on this is that education for individuals and families with serious mental illness is absolutely crucial.
Mm-hmm.
Our medications are only going to take care of persons, with issues with serious mental illness so far, and they might not always be the best choice for what's going to help our patients. Supportive therapies are also so vital to people recovering and for them to function at the highest possible level. So, education on this is also essential. And we provide education about how peers and how NAMI can be involved in individuals' care, both supporting them and their families, helping them navigate issues like the healthcare system, locating resources, advocacy. I'd also like to point out that, we as clinicians and educators, we realize that individuals with serious mental illnesses are whole human beings working toward their own holistic health. And they might need supports with more of the medical issues, or they might have a substance use issue. So we also provide materials for education for both clinicians and the individual family side on these related issues, and trying to do so in ways that are really the most accessible to everyone looking for assistance.
That's excellent. I love it.
I just might add one point to
Yeah.
that, and that is the title of our talk, of our podcast, is Erasing the Stigma. And everything that Dr. Rolin said would be geared towards erasing the stigma. Education is the only way we're going to be able to make these treatments available to everybody without prejudice and without stigma, so that they can avail
Absolutely.
themselves of it. Yeah. So I think
Right.
that's important.
Agreed. I totally agree with that.
Yeah. So you're giving a joint presentation at the upcoming American Psychiatric Nurses Association, or APNA, and the presentation is titled Using the Brief Psychiatric Rating Scale, or BPRS, as a Symptom Assessment Tool in Measurement-Based Care. Could you each tell us a little bit more about what the BPRS is and why it is important for clinicians to incorporate this into their practice?
So the BPRS, or the Brief Psychiatric Rating Scale, is a semi-structured interview that allows a clinician to determine the severity level, or how severe or how strong symptoms are in a given individual. It was initially published in 1962 and has gone through a series of developments. My colleagues and I at UCLA in the aftercare program recently published revisions of it. We took the 18-item version and expanded it to 21 items, and then from 21 to 24 items. Now, why is that important? It's because we made it more comprehensive, so that in addition to covering basic symptoms such as anxiety, depression, psychotic symptoms, we've expanded it to include suicidality, self-neglect, and symptoms of mania. So we've made it more comprehensive. And in addition to making it more comprehensive, what we've done is we've provided a definition for each symptom, and each symptom has a series of questions that the clinician can use to find out more information about the symptoms. And each symptom has a series of ratings that are from a scale of 1 to 7. So you could determine the severity of the symptom, and each rating has a definition. So why is that important? It's because for individuals with SMI, for some of them, depression and anxiety is actually more debilitating in some ways than maybe a psychotic symptom, which is under control from medication. On the other hand, another person might not be depressed or anxious, but may have hallucinations that are very troublesome, preoccupying, and distressing. In other cases, you can also monitor the suicidality level of individuals. So it's important because it helps you to be able to focus or target on specific symptoms that might need treatment, or for which the medications are not working very well. So then, as Dr. Rolin alluded to, you would need to provide a different form of treatment, like a psychosocial treatment.
That's great. Is there anything that you'd like to add, Dr. Rolin?
Well, I can talk a bit about how our presentation at the APNA meeting on BPRS will kind of focus on how psychiatric nurses can utilize this.
Excellent.
Dr. Ventura and I plan to present the different sections or symptom clusters contained in the BPRS tool itself, like he was describing. And since he was instrumental in developing the BPRS, he'll lead the participants through the details of those sections. But then we plan to discuss how psychiatric nurses can apply their expertise in assessment and interviewing skills, which is what they do very well, in using this standardized approach, which will enable them to use these serial measures with the BPRS in measurement-based care. So this will allow for more objective trending over time of patients' progress and treatment and so forth. And then lastly, during our presentation, we'll be performing some role plays of us actually using the BPRS tool.
I love it. That's great.
Yeah. We've had to modify our approach just a bit because the conference is virtual, like things are these days. But Dr. Ventura will play the clinician, and I will play the part of the individual being interviewed. We've got sort of a loose script that we're working from, but we feel like this will really give our audience a great vision of how this tool can best and really pretty easily be integrated into their practice.
Yeah, one way of thinking of the BPRS, or the Brief Psychiatric Rating Scale, is it's like taking the temperature of a person who comes in for a medical appointment. We get a series of parameters that are measured when we go for our medical appointments. Our weight is taken, we have our temperature taken, and so it's a basis for determining whether or not the person is experiencing any symptoms. So you can get a very fundamental baseline level of knowledge of what is actually troubling the person when you conduct the BPRS. If you repeat the BPRS over time, you could determine how the symptoms change over time and whether the interventions that you're using are actually working or not. This is very, very important. It sounds pretty simple, but it doesn't always happen that in clinical practice, all the symptoms that might be relevant are measured, and then they're tracked over time so that you could determine whether the intervention, the treatment you're using, is actually working on the symptoms that you want it to work on. So the BPRS allows you to do that in what we call a measurement-based care approach, which is what Dr. Rolin and I are going to talk about also during our presentation.
That's great. Well, you may have just answered this, but when it comes to scales, what is unique about the BPRS and what can it offer that other scales can't or don't offer?
There are other scales that work well too. What I like about the BPRS and what I've been told from people who use it, and it is one of the most widely used scales in psychiatry, but there are a couple of features of it that I like. One of them is that it's very easy to read the definition of the symptom. We spent a lot of time at UCLA when we made these revisions that I alluded to and that we published, making sure that the definition of the symptom was actually understandable and readable. We also include a series of questions that sound very conversational. If you want to find out information about what people are going through when it's distressing and they're preoccupied with it, you have to make sure that when you're bringing it up in a conversational way so it doesn't seem like a clinical interview. And some of our questions, I think, accomplish that. Next would be the fact that, as I mentioned, all of the anchor points, so from 1 to 7, they all have a definition. So, for example, everyone from time to time may experience a bit of depression or anxiety. This would be considered mild or very mild. But when depression is severe enough that it interferes with your functioning, then you want to make sure that you've rated that level of depression and that you know that then that could be a target for treatment. So the BPRS, I think, in an easier way allows for the clinician to be able to make that determination. It's very geared towards whether symptoms interfere with functioning or not. And that's what we find is very important. And then finally, it's one of the few psychiatric rating scales that has an item on suicidality that's, I think, is well defined as ours. So it really speaks to the fact that the importance of that symptom and that it needs to be monitored over time. Whether the clinician thinks the person is feeling that way or not, you have to ask people because they won't tell you spontaneously.
Right. Could each of you share a little bit more about what your presentation on the BPRS will be focusing on at APNA? And I know you already went into just a little bit about the format, which I think is so creative and wonderful. Is there anything else you'd like to add?
Sure. I can also say that, the conference meeting should be virtual this year. And so this will be kind of the first educational presentation that I've done in this manner. But Dr. Ventura and I will be recording our content and then the role play section as well, like I mentioned. But then the recording will run at a specific time in the program schedule. And then we will both be online fielding questions through the Q&A chat. And that's going to be really fun and interesting, I think. So along the way through the presentation, we'll be actively responding.
Okay, that's great.
Yeah, I would add to that some of the slides that I have are of individuals who were interviewed with the BPRS every 2 weeks for a year. And we have that data from our program, that the UCLA Aftercare program. So I'm really anxious to show these charts. Clinicians really, really like to see them because it shows how when you track symptoms over time, how some remit and some don't, how some get worse while others don't. And then we have some charts, some graphs that show how groups of symptoms may get worse all at the same time. And so I think that they're going to find that very illuminating.
Yeah, that sounds exciting. Thank you so much. Now, Dr. Rolin, these last 2 questions will be for you. I understand that you've had a group membership with the Neuroscience Education Institute for over 6 years now, and that you implement our educational material from our Master's Psychopharmacology program, or MPP, into your curriculum at the University of Texas, Austin. What made you want to do that?
Well, that's a fun story, actually. So I have personally been using NEI's Master's Psychopharmacology program and been a member since 2013. And I brought it to my university kind of by chance. I actually inherited my program's psychopharmacology course kind of last minute at that time, as the pharmacy faculty who used to teach it had left their position. So I was scrambling to figure out what to do on top of my other courses that I had to teach at that, in less than a month, I believe it was. It's been a while. So at first I had some conversations with some colleagues at APNA. I happened to be in a meeting and I thought, well, I would give it a try and I'd bring in the Master Psychopharmacology program as sort of a Band-Aid and adding it to my university course curriculum for that course that semester. We were already using Stahl's textbooks and I was very familiar with those myself. So I thought, rather than recreating the wheel, there's this program that exists and maybe it will be beneficial. And the results were really great. The students, the graduate students, as well as their subsequent employers after they graduate, who are mostly at outpatient mental health clinics and some inpatient facilities, they gave such great praise and feedback about the preparation level of the students as far as psychopharmacology competency as new grads in particular, because this is not a strength that new grads usually have.
Right. That's wonderful.
Yeah. And I thought I might as well continue using this and just kind of adding other elements to the class and integrating it. And I actually presented a poster at the NEI meeting in Colorado back in 2014 on some data that I had collected. Over the years, I've consulted with various universities and their Psych NP and psychiatry residency program directors about this educational approach. And since then, I've continually evolved this course, but I still continue to use the NEI MPP program alongside some live class sessions where we apply the knowledge to case studies, we work out medication selection, make dosing decisions, and really practice using everything that they learn in the MPP program. And I think this approach is really great. It really gives the new grads a tremendous knowledge base, really, in psychopharmacology, but also increases their confidence level.
Yeah, absolutely. It seems like it. What could you share with us about your own personal experience with the MPP program and the feedback that you did receive from students? And then my final question would be, who would you recommend MPP to?
Sure, sure. So I personally use it, of course, for the course that I just described in psychopharmacology with the Psych MP students, but other elements of it I use all the time. I use the app where you can look up drugs, and in particular, the feature about cross titration with antipsychotic medications. I think it's very well done. And from time to time, you'll get notices about new topics and new archived webinars and short videos that really illustrate concepts well. And so there are just so many useful elements. And I just love being a member of this program. And as far as recommending it to someone, really any prescriber of psychotropic medications would be their practice could be so enriched by using this resource, whether it's the web-based version and they're doing the full MPP program, or if they're just picking and choosing certain elements, you can get all kinds of continuing education credits in this manner, or just pulling the app out while you're seeing a patient, or you have, a complex case that you're discussing with someone else. So from psych MPs to psychiatry residents to psychiatrists, or even primary care providers that are, in the practice of prescribing some psychotropic medications, this would be a great resource.
Excellent. Well, thank you both so much for being on our show. Thank you for sharing such great information, and we're all really looking forward to your talk. So thank you, Dr. Rolin and Dr. Ventura.
And thank you so much for inviting us to be on this podcast. This has been great.
Thank you for having us.
This episode has been brought to you by the NEI Podcast. With nearly 100 episodes, you can find us on iTunes, iHeartRadio, Libsyn, and virtually any platform that you prefer to listen to podcasts. If you've enjoyed this episode, we ask that you kindly leave a review for us. Go to any of the platforms mentioned and leave a star rating or a comment. We'd love to hear from you.